fellows from AV could just come up here. But
We're back.
all right, excellent.
Harmony.
Perfect. Okay. You want to invite the panelists?
Yes, could the panelists please join us now from VA, from Trizetto?
Yeah, I think so. I was going to say, I don't need any more hats.
I think Zach knows who he is. Yeah.
What do I?
It wasn't in the book because he hadn't registered for the.
Got it.
So.
Trizetto. Okay. I will do it. So, for those of you who don't know me, Ken Mandel called me Blunto, and in fact I've registered the domain blunto.com precisely of that, but I'm going to use that to good effect today because we have such an exciting and charged agenda that I'm really going to hold our panelists in this exciting panel to 20 minutes each, so that we, in fact, unlike what I just did to poor John, we're going to actually have substantive discussion in our panel subsequently. So I'm going to be brief now, make the introduction one by one, and then 20 minutes each. And so I apologize in advance to our panelists that I will be virtually bringing the hook across the stage to pull you in. Jeff Margolis is chairman and executive officer of Trizetto, and I have to say he already endeared himself to me because he said the phrase that I always usually say, which is, please make it brief in the introduction. So that's already, I think, a very nice sign. So looking at his extensive CV, I'll just note that he is the former senior vice president and chief information officer at FHP International, and he's been instrumental in making Trizetto now a powerhouse in this space of personally controlled health records. And with that, Jeff, I hope that was brief enough.
Thank you. Good afternoon. I'm used to giving quick presentations as I spend a fair amount of time on Wall Street. My vocabulary is going to be significantly different from the previous presentation, so let me tell you why, and I'll give you a little bit about my background. How many of you have ever heard of Trizetto? Oh, that's good. Trizetto last December bought a company located here in Boston called PCHRI. How many of you have heard of PCHRI? Good. All right. Well, I'm going to come at you from a decidedly what's going on in the market commercial perspective. I'll give you some stats about what Trizetto does in the marketplace, but about 35% of the U.S. insured population is what we design solutions for and put in the marketplace. I was excited to come here today and have the opportunity. I've been in healthcare IT for 20 years, and along that path, I had an opportunity to be the Chief Information Officer, as Zach mentioned, for what was called FHP International. FHP International was one of the first large integrated delivery systems out of California. Millions of members in different health plan models. We owned hospitals, we owned physician practices, specialty, we owned pharma, we owned ambulance companies, we owned everything. And I had the opportunity to sit on top of about 2,000 IT development and service type people at that time. We actually took an integrated delivery system, which I think we're going to hear about more today, and we disintegrated it. We had the holy grail, hospitals, clinics, and health plans all talking to each other, sharing data, and we decided to pull it apart. So you can ask me why later. Began implementing personally the first electronic medical records into these clinics in 1994. Also got the opportunity both at FHP and once we started Trizetto to help work with physician groups and IPAs and different types of groupings of physicians in terms of how their practice management meshed with what was going on with payers and with other clinical aspects of their practice. I'll skip the next bullet point. I will say I spend a fair amount of time haranguing people in Washington on the very issues that were just discussed to give them a perspective that is decidedly less clinical than the one we just heard. Not because the one we just heard is not crucial, it is, but because there's a whole nother world of data and information operating out there that's extremely sophisticated and extremely well developed that has to find its way into the current legislation going on in Washington, and in fact, we're having success with that. They often say, I know the healthcare system and it knows me. I have had extensive personal medical background, which is, I'm not violating any HIPAA because I have, it's been published in a few publications like the New York Times, but I have Crohn's disease and several other things, so I've been misdiagnosed, I've been given bad meds, I've been sent to the wrong facility, I've had everything happen to me. And so I've seen the system operate from the inside as well. And in a group like this, I just thought I should say I'm also a CPA, which doesn't really matter, but my mother's very proud of that. The TriZetto is kind of a quiet company by design. We're quiet because we try not to get in between our customers and the consumers that they serve. But 330 health plans, payers in the United States are TriZetto customers. Over 100, I'm going to go to 140 million lives are in production on our systems for enrollment and benefits, payment of claims, reimbursement of provider contracts, customer service inquiries, personal health records, utilization management, case management, so on and so forth. And you can see some statistics on the right. We have a very strong market share in the Blue Cross Blue Shield organizations in this country who, off the radar screen, if you're a public company like TriZetto is, you always hear about the publicly traded healthcare payers, but there's these not-for-profit organizations operating in healthcare that are just marvelous, doing innovative things that are off the radar screen from the general investment public. And we have significant interaction with the Medicare and Medicaid programs that are government sponsored but run by the private sector. Now, health plans, again, I'm really going to change up the vocabulary here. We've been talking about, visits and lab results and physician notes and this very personal part where you touch, where healthcare touches you. And I need to have you step backwards to understand my perspective on this in terms of an overall systems approach. By background, I'm more of a system scientist and business person. I'm not a clinician. But health plans are the ones in this country that take and run and balance this supply chain that we have, and I'm going to talk more about that in a second. But we've got consumers who may come in the form of individual consumers or employer-sponsored consumers or uninsured consumers that somehow within an economic framework need to get linked up with physicians, with hospitals, with pharmacy, with equipment providers, and so forth. And the way that occurs from a systematic information technology standpoint is extremely complicated. It's the most complicated industry in the United States, and before I was in healthcare, I did work in banking and telecom and mining and manufacturing and distribution, and a number of other things. I came into healthcare because I love pain, and it's a very difficult field. And you can see in the middle here, there's about 150 plus million employer-sponsored people, consumers, patients receiving health care that are run by health plans or payers, 18 million individually insured, that group's going up, and 30 plus million in managed Medicare and Medicaid, and actually with Medicare Part D, we just saw the biggest leap up in terms of a program going into place in a couple-year period that we've ever seen in the history of Western civilization, I think, and really, while you can argue about certain merits of it, I think very well implemented by the federal government and by its partners. So what we talk about at TriZetto is keeping payers at the center of the supply chain to lead the transformation of the industry. And what this should do right away, if you think about the slide John just put up, is go, aren't consumers at the center? What's he saying? Payers at the center? And what I'm explaining is that it's not that consumers aren't who we're trying to center around, but it's that the entities that are capable of running the information technology infrastructure to keep all these pieces flowing in a supply chain, efficient-like industry manner, happens to be the payers. Not always a popular message, but the information technology infrastructure of the payers to do this is what payers do today. And so really, you've got, we've already talked about employers and consumers and providers in the last, but we didn't talk about brokers. Pretty important constituent that actually gets the consumers to enroll in or be part of or participate in healthcare programs that they're in. They happen to be extremely powerful, a part of this supply chain that have to be managed as well. Okay, so that just sets a little background on a payer perspective. Now, as I said, I've been spending some time in Washington, not enough, because I also have the business to run, but what I found is that the types of initiatives that have been started in Washington and that are undergoing standards vetting processes and so forth are very well intentioned, but they are the terminology of clinicians. And even though payers are getting involved in health plans and so forth, the terminology and the whole construct and the way it's being written into the bills and so on and so forth has the feel of clinical types of approach. And that's okay. But what we need to keep in mind is that anything that creates a higher awareness of the use of information technology in this country for the improvement of healthcare, that's a good thing. And from my perspective, whether it's hospital vendors or physician vendors or pushing and lobbying and doing, I think it's all great because, ultimately people have to get made aware that just like every other phase of American capitalistic society uses information technology to advance the cause for consumers, we have to use it in healthcare as well. But what I don't think always is understood, because most people have been to the doctor's office, most people have been to or visited the hospital, but very few people have ever been in the back room of a health plan. So what goes on in the back room of a health plan? Is it important? Probably not to most of you, but let me explain a little bit in the underlying infrastructure. What health plans do is they keep track for an individual consumer of what is their benefit plan. So what coverage are they enrolled in? What do they have coverage to access, if you will, and how many visits can they have, to what type of provider, so on and so forth. The health plans also keep track of what is their physician network, what is their hospital network, what is the pharma network, what are the reimbursement arrangements to those different players. How does that vary depending on when, how, or who you go see, or which rule set you follow, which goes to the third one, care management protocols and access rules, which is, again, saying if you see a specialty provider when you should have seen a primary provider in this particular situation, or if you go outside of your network without going through step A, B, and C, then as a consumer, you're going to spend more money out of pocket. And then we talked today about transparency, but pricing transparency, quality transparency, healthcare information transparency, these are all things that can only be relevant really in the context of all these other constraints. what are my benefits? What is my provider network? What are the rules I can access? And therefore, how is this other transparency information relevant to me as a consumer at my point of interaction with the provider community? So it's the health plans that already are in the business of keeping this stuff below the tip of the iceberg rolling, if you will. Now, from a data or an IT perspective, I just want to come at this from the opposite way of working from the doctor's office out. Again, I come from out west. I grew up in Boulder. We had a hospital. And so I find a lot of people that are existing in environments where there's multiple clinics down the road from each other, associating with one another, where lots of the providers are in a shared medical community, so on and so forth. It feels like we're this far from being able to connect this stuff all together. Well, that's not the normal case, okay? The normal case is that you have a consumer, and the consumer goes to multiple providers at multiple locations. They go to different facilities to be treated. They pick up their prescriptions at different places. They have differing financial relationships. Their lab results come in based upon where they went for their clinical interaction. And these are all somewhat difficult to control. But for a period of time, from a data perspective, there's only one health plan relationship, one primary health plan relationship to that consumer. And it's the health plans that keep track of what are the diagnoses, what were the locations, who saw that patient, on what date did they see them. And this level of information I want to talk to you a little bit more. But this is what creates the opportunity for the payer to be at the center of the supply chain and help in terms of dishing personal health records or providing personal health records for consumers. I like to talk about different levels of abstractions. This vocabulary may not be acceptable to all of you, but I look at what the market sells and buys, less so than what gets defined sometimes. And we look at three different levels of abstraction. In hospitals, clinical facilities with great specialty, there's electronic medical records that have very deep, thick, data-intensive records that are meant to be read and utilized by top specialists. A layperson can't deal with them. Most clinicians maybe can't even deal with them unless it's their specialty. You go over to the right side, you've got electronic health records, and electronic health records, think about that as the automation of the clipboard from the Seinfeld episode, if you will. But there's another level of abstraction is what I'm trying to get to, which is the personal health record, which comes out of the claims data that is contained by the health plans or available by the health plans that allows for health plans to quickly create a snapshot. We talk a lot about the 80-20 rule in business or the Pareto principle. How do you get 80% of the way there for 20% of the effort? And what I'm suggesting to you is that with this data, inaccurate and incomplete as it may be from a clinical perspective, it's still a heck of a lot better than trying to work your way from the needle out of the haystack, as opposed to looking at the whole haystack. So essentially, what I'm talking about is a level of abstraction of the personal health record as a health resume, or using the claims database as a search engine. Because if you know what was the diagnosis, who diagnosed it, at what facility, on what date, you now at least have the roadmap to dive in to those other systems while we're waiting for interoperability and sharing to automatically appear when the person from Connecticut gets in a motorcycle accident in Arizona and their records pop up, in the ER. I don't think that's going to happen in my lifetime. I hate to be a skeptic, but I do think what can happen in our lifetime very quickly is that the person's health resume or health history, that we can know what they've been diagnosed with, where they've been treated, and where their records could be made available, so that either through automated or conventional means, we can pull those towards the consumer. I'm going to skip this slide for time, and I'll just finish just saying, so this isn't just theory. We're in the market now, and we're providing personal health records that payers provide on behalf of their members. And the typical standard notion of a personal health record or personal health record light is just some basic health history, and the way we view the world is much more like John was just talking about, is you have to get dynamic in terms of the way you go about populating and filling out that personal health record, because I think his statistic was 42 people out of 40,000 interactions monthly actually put in their own data. Yeah, we know that. People aren't going to put in their own stuff. But what the health plans have is they have eligibility information, predictive modeling, PBM feeds, claims data, pricing data that can all feed through a rules engine and present to the consumer the relevant health information to them for their situation at their time under the constraints of their benefit plan, their provider network, their rules for medical management. And you can supplement that with consumer content, just as was presented in the last presentation. I'm not going to list how we do it because this isn't a commercial forum. But this particular model is the definition of the advanced personal health record from a payer perspective. And it's meant to deal with an environment where you don't have a contained hospital, physician, clinician relationship all wrapped up in a staff or Kaiser-like network model, but more for the normative situation in the country where you have people going to multiple places in a more of a random cycle. Okay?
Thank you very much, Jeff. And we are indeed going to have discussion, but at the end of the three presentations. The next presentation is from the Veterans Administration. We have two presenters, Dr. Syed Tirmizi, who has been involved in medical informatics at the VA healthcare system since 13 years, and is involved in training, and also Virginia Price, who's in charge of the My Healthy Vet PHR product. And I want to say that Dr. Kolodner, who's now gone on to become the head of ONC, has been a chief driver at the VA when he was a CIO there. And so I think that we have a lot to learn from this group.
Thank you. Appreciate the invitation from Bill Crawford as well as Ken Mandel for us to share our experience, but more importantly to learn from other best practices so that we can continue to evolve our product here. There has been increasing awareness of the utility of EHR as part of physician practice and the benefits from that, but there's not much as by way of what a personal health record does, and of course, this meeting and others will provide some data. But looking at a Harris Interactive survey that was done in 2004, we see that 20% of patients in the US keep their own personal health records. 13% keep them electronically, and 40% are planning to do so in the future. More women than men keep their records. 58% of over age 65 fill the information about their treatment, and also of the patients who were surveyed, 84% of all surveyed patients welcome the idea of a PHR. Of the 13% that kept the records in the Harris survey, they said only 1 in 13 kept them online at a health record website. In a study that Angst and Agarwal did also in 2004, they looked at what is the value in a PHR that the patients are looking for, and principally it is for the family medical history, also to track the doctor visits, the lab tests, the medications, and also to trend health data. They also looked at what are the predictors for personal health use or the desire for the use of PHR. Convenience was a strong predictor of the desire for PHR. Compliance was also a predictor. Connectedness was a predictor. However, age and chronic illness were not predictors. However, education and knowledge of PHRs were predictors of the desire for personal health records. Angst and Agarwal also looked at how comfortable we would be if a personal health record was provided to us by a stakeholder. On a scale of 1 to 7, 1 being very uncomfortable and 7 being very comfortable, we see that both the patients and the doctor see that if it's provided by the doctor or the hospital, the comfort level was between 4 and somewhere around 5.5. However, they were very uncomfortable if this was provided by employer or by the pharmaceutical or special interest groups. We use the chronic disease model, and the personal health records are going to be driven because majority of the healthcare costs in the U.S. are related to care of chronic disease. And what the system we have is we have the health system, which is organized healthcare, working with the community, using an information system, in our case Vista, with decision support and a delivery system design and self-management support, working together to have a productive interaction. And this can be made more productive if we have a prepared, proactive practice team and also an activated, informed, empowered patient, so that the care is patient-centered, it's coordinated, timely and efficient, and evidence-based and safe care through the use of electronic health, personal health record, for hopefully with improved outcome. Actually, there's a lot needs to be done to research to see how outcomes are improved by this. What do people with chronic disease need, and how can personal health records support that? There is a need to have a continuous healing relationship. Also, there needs to be regular assessments of how patients are doing and effective clinical management. Information and ongoing support for self-management of patients either at home or elsewhere is important, as is the shared care plan between the patient and the treatment team. And also an active, sustained follow-up to bring that relationship, which is very critical for management of chronic diseases. So why My Healthy Vet? The challenge we had, and this was going back when we launched this in November of 2003, the challenge was how do you further improve the quality and humanity of healthcare, and how do you close the quality chasm? We saw the solution would be, one of the solutions would be My Healthy Vet, where we would have an informed, activated patient, patient-centered care, improve the quality as well as access to the care. What are the benefits to the providers with PHRs? One is to transfer the ownership of chronic disease management to the patient, where the patient becomes part of the treatment team. And we've all seen where many in the industry use us as part of the management of whatever system they're providing. Particularly the airlines, we all go online, make our reservations, seat assignments, and even with Southwest, we get up early in the morning, 12:01, to get the air type of seating assignment. So we are all working for this industry, and we can have our patients become part of the treatment team, where they can put information into the system, or at least the technology can help do that. It offers more complete picture of the patient's health across the system, and also including non-VA care, because many of our patients have dual care from the private sector, and it's very important that we have complete information. Also, since we have the patient participate in the care, we can reallocate the time for more complex cases in the clinic and have patients better managed through a personal health record. And also to have the ability to communicate and collaborate with patients more easily, as was published in an article by McKay in 2001 in Diabetes Care. They found patients who participated in an online diabetes education support group lowered their blood sugar significantly more than the controls. What are the benefits to VHA for our personal health record? It offers us a one single touch to read the entire population. We are able to broadcast bulletins like SARS, flu shot. We also have interactive outreach for health education, VA-specific programs, opportunities to participate in research, and that, of course, can be expanded. Plus, what I have not mentioned here is perhaps with public health surveillance, with the E. coli outbreak, and recently, we can quickly look at some of the data from what patients have entered from home and see if we can trend any of that data and also enhance patient satisfaction. What's all about the veteran? We have a patient-centric care away from a provider-centric care which existed in the past. Care where the patient is the focus of the care control. Care that integrates across all environments, whether the patient is in ambulatory care, inpatient, or elsewhere. Care that integrates across when they're healthy as well as when they have a medical condition or other conditions. Care that anticipates needs rather than just reacts to it. And I think this is where the patient's needs could be, like in the case of Katrina, we saw that there was a need to have a medical record, and we all reacted to it, said we need a solution, and PHR was considered as a solution for natural disasters, and I think that was a reaction, but I think we need to be anticipating such situations. And also care that works with patient in non-traditional environment, like home care, where we can have technology support input of data directly into a EHR and PHR. The role of the clinician in achieving, again, these are the benefits we've discussed. I'll quickly go to the next one. Here, veterans are using this extensively. They're using it for health information. They are now participating in putting in the data. They're entering blood sugar, blood pressure, heart rate, body weight. They're also entering pain levels, allergies, and immunizations where appropriate. And they're entering information for us for health insurance, for healthcare providers, military health history, and pulse oximetry, and they also download food and activity. They are also processing their refills online, and they are accessing health information, Medline Plus, HealthWise, and all the components of that. Here is a usage, we have data right to October the 4th here. We have crossed in the cumulative yearly visits, which is up from in the January to September 2006. The visits have been up by almost 12%. And actually on October 4th, we crossed the 4 million visits. And in the new patients enrolled, as you can see between the comparison for the last year in blue with the maroon for this year, there's been a 90% increase in new patients signing up for the personal health record. So we see that there's being used, even though we hear that the world is flat, but where Bethesda, Beijing, and Bangalore are connected, but in healthcare, I think it'll take some more time to have that connectivity that we're looking for. Thank you. I'll have Ginger.
Thank you. Well, it's my great pleasure to be able to tell you about the passion in my life, and that is the personal health record. Putting feet to the street is really where this is at. We have had tremendous clinical leadership in VA with a vision to 2020. And my job has been to keep my feet on the ground and see if we just can't do this a little bit by a little bit. So a lot of the things, first of all, I got to find out how we, oops, I'm in not good shape here.
It's the emergency backup tablet. PC,
Thank you.
so
And then
just hit space.
just hit space. All right. So we had a vision that this was going to transform how the VA delivered health care. It was very clinical in nature, and we have doctors who are using CPRS, and the challenge is how do we get the information out there to 26 million veterans? This is available to 26 million, not just the 5.2 that we treat. And how do we get them to know about it, to use it, and to engage with their doctors and bring this information back? We know that their compliance is going to help them. How do we create that doctor-patient relationship that's going to bring this home? We had some principles when we started out that the veteran would own their personal health record, that CPRS inside of VA would be the authoritative VA medical record, and what the patient gets or the veteran gets is a copy of their electronic record, which they own. If they put things into their eVault, then they must give us their permission if I'm ever going to transmit that also to VISTA to become a part of their record. And that this would be available to all veterans and to all VA employees. We did a little bit of benchmarking. We asked veterans what they wanted a PHR for, and the interesting thing that they said what they really wanted to know was that they wanted to know that their VA caregivers are plugged into what's happening to them and that they care what's happening to them between visits. And clinicians wanted the usual things. They wanted information, they wanted to be able to give better care, they wanted a complete record, and they wanted that outside information. They wanted their patients to be able to check in on these things at home. So I'm still working now on things that were set out in 2003. I still have not delivered on the complete contract. We will deliver this December with the VISTA portion of the record, which starts to bring over those things from VISTA and give them to the patients. We are piloting this at 9 sites across the nation. In order to do this, we've had to go to a lot of external things, such as in-person authentication. How does this happen? We have to have the patient go down and actually upgrade their account from a light-proofed account to a heavy-proofed account before we can give them the information from their healthcare record. So we've had to build ancillary systems around this to be able to manage those user roles out in the field of people who are able to proof these veterans and then actually give them the VISTA EHR. So we've pretty much delivered on target. We do have our graphing, our family history, our past medical history, and we involve the veterans both in usability testing and in telling us, the voice of the veteran, what is it that they want to see. And we're trying to deliver in great measure upon their time frame. What they want is they want that patient-provider messaging. We will be prototyping that in December. And strangely enough, when our delivery schedule pushed out for that, we got kind of a vent from our clinicians in the field. At first they were saying, no, we don't want this. It's going to up our workload. And now, since we've delayed putting it out there, we're getting a whole lot of push. Why don't you have this out there? This is the #1 thing we need. So that's been a good thing. And delegation, which we have piloted and are showing today, the veterans want that very much. That will allow them basically to give as much or as little access to their personal health record to a person of their choosing. In fact, to be able to be a delegate to take care of their entire care. What does success look like? We do have some benchmarking information. I'm going to kind of go over this very quickly. But to make a long story short, right now, most of our information is apocryphal. I'm getting the hook sign. All right, 5 minutes. What we have found out in our pilot testing is much the same thing that other people were mentioning. At the beginning, there was a lot of negative expectations out there that this was going to increase their workload. Telephone care would be absolutely deluged. Patients would be dissatisfied. They'd be getting their health care information. They wouldn't know what it meant. There would be mass hysteria. And that basically that the hospitals would be clogged up with people sitting there saying, explain this to me, I don't understand it. That hasn't happened. Out here in Portland, they have over 5,000 patients today using the pilot, which gives absolute full access to 18 extracts of VISTA information, including progress notes, including problem list. They have not found that happened. Patient advocate complaints didn't happen. One congressional complaint did not happen. Not one report of a patient misinterpreting or overreacting to medical data, and these include the mental health progress notes. So what we are finding as we put it out there is that they want it and they are not reacting to it badly. We know that we are going to have to make massive changes in the way that we deliver health care. So my biggest challenge right now is clinical adoption. We have the clinical advisory board, and they are coming in to us and telling us what is it that it's going to take. They've helped understand that, oh, we can put the education out there and we can put the opportunity there. But the responsibility between the healthcare provider and the veteran to create that connection between their lifestyle choices and what they do in between visits and their health outcomes, it truly is a change in the way that we deliver care. And a key to that, my clinicians telling me, is going to be recognizing their progress. Hey, that's great, you're halfway to your goal. In that interim between appointments. So we've come up with this from our clinical advisory board. These are some of the things that we're doing out there in the field today to encourage the patient to get a PHR, to use a PHR, and to bring in the results of this in between meetings. Things we're going to do. We do have a heavy security component with this. We do feel that patients need to understand that when they get this information electronically, it is then out of our hands, and they need to use great discretion with whom they take care of this. If they print it off at the hospital and take it with them, they need to be very careful with it. So we have educational videos, and we actually have them review this before they are able to sign up for an account. We have a list for our healthcare providers also for how they can get involved with this, and they actually have put us on a glide path to, they want training plans and treatment plans in there that become shared clinical objects where the patients can come in and fill out that information before they come in, and they can fill out things later. So they've started to help us design, actually this is our provider toolkit, where they get their pocket guide, they get cards that they can give to those patients. So they can take the URL home, they can have somebody in the hospital as they get finished with their appointment that can go and help somebody get grounded here. And they've helped us design what we're calling an ERX so that they can check off those things for the patient to take home and do in the meantime when they come back to their next assignment. Tie it in with goals, research following health topics, and we're going to try and work that into some information prescriptions that our clinical advisory board is telling us now. This November, we should come out with what we are calling condition centers. We're starting out with heart failure, stroke, and diabetes, and then wellness centers, which are smoking cessation, exercise, and right eating. So as we work these things in, they map into our clinical practice guidelines. We're getting the patients involved. We're giving them homework. These are some of the things that we are trying to do. Did I get my 5 minutes?
Amazing job. Thank you.
I'll write that down.
Well, first of all, thank you very much for complying with the time guidelines. It really helps us get to the discussion, and yet you were extremely informative throughout. So Ken Mandel is an emergency room doctor, a leader in public health informatics, and one of the drivers behind the Indivo project that you'll hear a little bit more about.
Hello again. I don't have any financial disclosures to make, but there's two that I'd like to make, and that is that a lot of our work is very generously funded by the National Library of Medicine and the Centers for Disease Control. We're going to look here at some models of personally controlled health record infrastructure. Okay, and we're going to start with an example from this trio of RIOs, as it were, that has come together under the CSC and Markle Foundation project for ONC, where data are exchanged among Indiana, Massachusetts, and Mendocino County. And we all know where we would like to have our meetings most frequently, of course. The example that John alluded to is of our CIO at Children's Hospital, who very openly agreed to participate in this, and actually helped to let us have a very nice demonstration that came together last Friday, so just 4 days ago. And what he did was to exchange data across regions. And in some ways it's a small achievement, and in some ways I think it's kind of exciting. And so he first he created, okay, with the yellow arrow, he had to create a record. Okay, so he did so here, creating this record. Now, he actually typed some medication data in. So he'd be one of those 42 patients in patient site. And we're looking to integrate very, very soon the pharmacy benefit management data, which has its own set of issues and will still require some typing by somebody on top of it. So those are some of the things we're looking at. But he created this, and we did it with some typed-in data. And then he actually got a data feed, okay, the kind of data that you don't have to type, into the record from the hospital. And this was through an entity we call a subscription agent. So the subscription agent exists, and all he really has to do is sign up to use it, and the data pours into his record. Then he also subscribed to the MassShare Rio, okay, and that action added to his list of subscriptions where he actually is able to populate his record from and share information with. So the subscription to the MassShare Rio in particular creates this yellow arrow, which notifies the record locator services to the location of his record for future use by healthcare providers. Goes to Indianapolis, okay, and ends up touring the city, and this part is fictional, lands in the hospital, okay? Lands in the hospital there, and so what needs to happen now? So Indianapolis, so an emergency department provider in Indianapolis who's seeing him will take, will create a query back through this great piece of terminology, the intersnow bridge. Okay, it's truly like, this is like 23rd century stuff. This is the inter-SNO bridge. So that's the SNOs are the sub-network organizations, and and regions can have their own flavor and their own protocols as long as they can talk to the inter-SNO bridge. So they, through this inter-SNO bridge, they locate the record through our record locator service here in Massachusetts, and then because HL7 is a terrific standard for transmitting this, we used it as an example, and transmit a bunch of data through an HL7 message back through the inter-SNO bridge again and back to Indianapolis. This is an actual screenshot from yesterday of a probably unaware physician sitting next to Dan's record on a, it's very shy, on a PC, and it's real, you know, in that it really, those data really did go through this routing process that I've outlined and really did show up in a viewer in Indianapolis on Friday, and the photograph was taken yesterday. And, you know, we think of this a little bit as the sort of the Watson come here, I need you moment, where we had end-to-end connectivity across these regions. Oh, sorry. I've been meaning to talk to you about that. Okay, so how do you do this? How do you think about this? And where does the personal health record fit in to this kind of exchange? It's really more complicated, and John drew the abstraction layer clearly outside of where he was to deal with a lot of the complicated issues. Let's just take a look at them and take a look at some models of personal health records. So there's the tethered personal health record. Okay, so this is essentially what I mean is the window onto a database for an individual institution. Okay, so that's where Epic has a wonderful one. Okay, that's being deployed throughout Kaiser. Patient Site is such an entity that John talked about here, and these were really the first generation of personal health records to get out there. So, secondly, okay, a personal sort of national health information network gateway via a care delivery organization. Okay, so here we have, in this blue square up there, we have a personal health record that is that is created because you have a relationship with a hospital. John alluded to that. We are able to authenticate you because we know you at that hospital. Okay, and then that hospital, along with all the other data sources, is located, and the personal health record is located through the record locator service. Okay, and there's roles here for interconnectivity with other regions and for or other RIAs and SNOs and with public health. Now, this essentially replicates the existing web of trust. So a doctor knows you, they let you register. Now, I truly believe that I could walk into the Brigham right now, even if I was not a physician, and start performing surgery on a patient. Okay, so that's the current sort of web of trust. But at least we're at that level. We're at least at that level. And I certainly could go to medical records and get someone's medical record, right? If I just said who we don't look for passports and fingerprints in hospitals, and people show up and I could certainly get surgery pretending to be someone, right? We all know this. So we have the existing level. We want to at least replicate that. We don't want to just put up a website where people can create their records and be whoever they are. And hopefully we want to move beyond this. And I think that that's something that actually should be touched on, let me encourage you, in all the tracks. Okay? How do we know who you are? There are societal issues, there are technical issues, and there are certainly business issues here. And it is it's on a critical path. Okay. The tethered personal health record. The personal health record, the personal gateway via a care delivery organization, and the personal NHIN gateway via a PCHR service is number 3. So here, instead of coming in through a hospital, you're coming in through an independent organization that's handling your personally controlled health records, and other things are the same. Once again, the key piece here is how you become known to the system, and once again here, the PCHR is another data source found by the record locator service, this time unlinked to a hospital. Lastly, okay, is the PCHR-centric or Aristotelian model, okay? And this does put the patient Now, so you can see that the Aristotelian model for him might be the payer at the center of the universe, so that's okay. We can all interpret Aristotle in our own ways. And here we have, okay, the personal health record at the center. And here we have the patient is actually, there is besides the fact that the diagram is configured differently, and that these diagrams can be very boring to look at because they're just diagrams, the fact that the patient is here actually in the middle with a personal health record is an important distinction. And I'll point out here that we still have the SNOs. You can still interact with other regions, okay? But this is kind of zoomed in on the patient part, and let's see what the patient can really do in this model. I'll just, as an aside, I'll just say, and this is where the Markle Foundation is doing a lot of work, how do you federate among all these different personal health record providers? That is also not an easy thing. I'm not going to be able to deal with that in detail here, but it's a very important piece. So here we have the Aristotelian model, and and the main reason not to subscribe to the Aristotelian model, okay, is because you do not believe that patients should control all information flow. All right, now, there may be good reasons to believe that, okay, but I think that is the reason that you would not have the patient at the center controlling the information flow. Now let's just think about some kinds of data that you wouldn't need the patient to be controlling, okay? So there's so-called de-identified data. There's mandatory reporting data in public health, okay? And then there's data for surveillance. These are three examples of data that are often flying around, not under patient control. And let's just look at these a little bit. So LaTanya Sweeney showed that a really stunning statistic that I bet some people in the room, but not all, are familiar with. So I'm just going to reiterate it. If you just take date of birth, zip code, and gender, and you link that back with voting records, you can re-identify 87% of the U.S. population. So here's the thing. If you're just going to use de-identified data, your data may be very boring, okay? Or it may just be, there may be just aggregated counts, like, yeah, 100 people came in with that. That's de-identified data. But as we move into the genomic era, those data are very identifying, okay? As we look at spatial relationships and, geographical information systems and that sort of work is critical in public health and health research and research around it. These data are very identifying. Any note, okay, is identifying. Do we want to start to confront the fact that the data are going to be identifying and think about how to deal with those and have the flows for those data also happening? Mandatory reporting in public health. Very interested in that. In fact, I co-direct a center of excellence in public health informatics, and half our work is on personally controlled health records, and half our work is on public health. That's a CDC center here in Boston. But is that a RIO function? Okay, is that between the institution and the public health department? Let's think about that. I mean, do those data actually need to fly around? So sure, if you have meningitis, there's a statute. Your name and your social and your date of birth, your medical record number, and your lab test will be transmitted to the Department of Public Health, whether the patient agrees or not. And there's not a lot of public debate about this stuff. But is that part of this? Is that what we're talking about here in these data exchanges, or is that something different? Surveillance. Okay, so public acceptance of surveillance is going to play out in some way. Either people will buy it hook, line, and sinker, and they may. Okay, or there's going to be the danger of opt-out. Okay, what John didn't mention is that in Mass Share Rio, he actually has an opt-in model for Mass Share. So patients have to opt in. So we're looking to confront privacy head-on by exercising individual rights to information and see the patient as the integrator of his or her own medical record. And again, see the patient as the integrator of his or her own medical record. Okay, so in other words, the patient requests the data. Okay, so we're just going to do a quick scorecard for these three four models that I presented. And the scores are going to be based on three areas: personal control, public health and research, and completeness, okay, which I think are three salient features of what we want to achieve here. So I'll say a quick aside about these different scoring criteria. Privacy and personal control are very intimately linked. So in April, the ACLU wrote a letter to Congress, along with 25 other organizations, saying that in the NHIN there should be more personal control, and we're concerned about identifiable information flying around without personal control. That may be a flash in the pan, or that may be the beginning of public reaction, as the average person on the street does not know that we're meeting today and does not really know what we're really talking about, okay? And so when they find out, we'll see what they say. So we're moving towards a system of opt-in and opt-out, which I think is appropriate. However, the danger is a massive opt-out or a failure to opt-in, okay? And that would be basically from a loss of trust. So if there was a loss of trust, people might say, I don't want to be a part of this anymore. And that's one thing I'd like to defend against as we go forward and build this system. So personal control allows HIPAA-compliant sharing of medical data for public health and for research. And in this role, patients can access the record, grant access to others, store their record in the location of choice, annotate the record. I was very pleased to see that many of these functions are actually being now built into the VA system, which is terrific. This is privacy, where the caps at the bottom says your medical records are safe with us. We take patient privacy very seriously. Okay, and this is a very familiar scene, I have to say. So surveillance. All right, so I spent a lot of time working on, it's perfect timing, I spent a lot of time working on surveillance, and I like to be able to detect outbreaks and show where they are. So I'm very, very interested in being able to do this the right way and having the data available to do this, okay? This is a biosurveillance system that we run for the Massachusetts Department of Public Health out of the informatics program at Children's. So, and again, the third piece of the scoring criteria is completeness, and one reason we're having the meeting today is fragmentation, okay? Ironically, this technology, this integrative technology, okay, is itself fragmenting up, okay? And at this moment, it looks like Americans are going to have the opportunity to have maybe one set of harmonized standards, but many personal health records, okay? And let's just, I would encourage us to think about, while we're here for a day and a half, what that means and what we want to come out of this from that perspective. Okay, so here's the scorecard. Tethered PHR. So identity management is occurring by the care delivery organization. Patient information access is a website at each site of care, and data aggregation, there is no data aggregation. Okay, so personal control, this is not really personally controlled, although I see from the VA that some personal control is actually being built in to a system like this, which is very interesting. Okay, patient site today doesn't have that. They're working in the RIO model for personal control. Public health research, no more than just if the system existed by itself. And completeness, the scoring system here is Lincoln Memorials. Okay, it's one Lincoln Memorial for completeness because you have the full data from that system. Okay, and it's context specific. Okay, so at the VA, that may be the full data. Okay, which is great. Okay, and somewhere else it might not be. Personal NHIN gateway via CDO. Okay, so again, this is the model here, and the scores are personal control. There is some personal control here, but the part where John sort of kind of pushed the model back towards us in terms of the authorities, that is hard. Okay, and figuring out once you enter your personal health record into a RIO, you lose some of the control around where that data will go and what it's be used for, and you have to trust the system more. Public health and research, I give it 2.5, and it would be 3, except for my concern about this opt-out. Okay, if it wasn't for opt-out, this would be the only solution we need, potentially. Completeness, I give it a 1. Again, it could be more. The reason I only give it a 1 now is because it's dependent on the development of the sub-network organizations, and if that accelerates quickly, this goes right up to a 3, okay? Via PCHR service, very similar set of scores, okay? And in the personally controlled Aristotelian model, again here, so for personal control, this is a personally controlled model, okay? So it's a tautology, but it gets a high score. And we provided a sort of vision statement we made on this in 2001 in your books. We think it's very important to think about personal control in this context. Public health research. We give this a 2.5, now not because of opt-out, but because non-participation is a factor. Okay, you might not have a personal health record, and then the public health people can't see you. Okay, so we do not give ourselves a perfect score on an Aristotelian model. All right, but completeness, I think. Back in public health, one more point. We also provided an article of Zach Kohanes from New England Journal, fairly recent, looking at people sharing genomic information for the public good. I think we have to think about this model in public health, okay? Which is why you say, well, why is this in my book? That's why this is in book. We have to think about people sharing their record data as well for research in public health. People share their data for research now, willingly. People share their data for public health. They don't usually know. But still, I think we should think about having informed consumers. What these experiences in patient site in the VA have showed are people are really willing to do this. They're really willing to participate in these things. Completeness. Completeness, I think, is very good. Now, this is, I think, the only point of potentially true contention, but I think that if people hook up to their individual sites, that will accelerate more quickly than Rios. Just a guess, okay? But I think both models should be pursued in parallel. And is there a business case for doing it this way? Okay, and again, this is very high level. I want you to follow this up in the track. But there is an interoperable core in a model like this, where you need some kind of standards for how you're storing this information, standards for even prescription agents that get the data from places, some standardization on how you get the data and how these institutions present the data, and some way that I have an encrypted data store. That's how we do it now. Once the network is up and running and available at all times and there and mirrored, in places that don't have earthquakes, and all this kind of stuff, then you have the opportunity to do this on the fly. There are opportunities here to provide services in the interface to this, okay? Major services. These are really sources of competition among sites of care. You have the opportunity actually to provide external services to the PHR from public health. Decision support could be provided externally, and this is another place for competition. There will be competition for at least the bandwidth of these patients. I will just end on the following note, which is that why do we all of a sudden care about this so much? Well, one reason is because we have the technology now that will actually enable this to happen. The other is that primary care is just not what it used to be. And I think we should recognize explicitly that part of what we're doing is curating a patient's information in place of the old country doc who used to do that for a family for their whole life, okay? And we really do have to recognize that people are not being looked after in the same way that they used to be by an individual who's aware. And if the information is not there, there is no individual integrating this information. One cartoon to end, and this one more motivation, and it says, I have no idea how you died. We don't have access to your medical records.
On that note. So now, thanks to the diligence of our participants, we actually have a solid 15 minutes before we unleash you on the refreshments for a discussion. What? Yeah. All right. And then we'll have something to say. So take a deep breath. Does anybody have questions? We've really seen, I think, a fascinating range of the different parts of this problem. Does anybody have questions, challenges? Yes. Okay.
I have a question for Ken, which has to do with disclosures under HIPAA and how that works into your model of the patient-controlled healthcare record. So, as a patient, once I share information with a provider, that provider basically can use that information to provide treatment or get payment. So it seems to me that there needs to be somewhere in this notion of a patient-controlled healthcare record, the notion that once you let the cat out of the bag, once you push it into that otherwise legally controlled domain, that I've now lost control. And I don't see anybody actually addressing that issue.
So that is an excellent point. And it is I'll broaden it and say that I think in addition to the current uses of healthcare information that a patient may release, there are actually potentially new opportunities for patients to engage in either self-serving or altruistic sharing of their healthcare data. And the idea of trying to control that data beyond the initial use is, again, very good grist for these conversations that we're going to be having. I'll just forward point to a society track panelist who will be actually addressing interesting opportunities from the Creative Commons, who will actually be addressing opportunities to even license, to send your information out with a license as it goes forward.
And I will just do a forward pointer to the technical track, which I'm involved in, so I want to put, or use DRM, digital rights management software. We can't prevent illegal things from being done. We'll never be able to prevent, but can we do the right bookkeeping so people know what they're allowed to do? I don't think we could ever prevent illegal things from happening.
This is not about illegal things. This is about, it's protected under law that I can use, if I were a provider, which I'm not, I would be able to use the information I have to provide treatment, including sharing that information with other healthcare providers. So, as a patient, once I give it away, effectively under HIPAA, it's gone.
I think these will end up being. Ken, do you want to say anything?
I think just to keep.
We'll keep this as teasers for the tracks. We really have issued substantial time for the tracks. Other questions? Yes, Solovich.
So 20 years ago, I had a discussion with CMS or and they had some interesting records about things like how many events rate but they had no information whatsoever on what the results of those events were. So what I'm wondering about is listening to Jeff's presentation about Meadows' view of the business model. If you look at it from their perspective, how much do they actually know about the clinical content of what happens to their patients?
And the answer is more than most people think and less than clinicians want. And what I mean by that is the results of those tests and the resulting diagnosis and the procedures performed to achieve those diagnoses, the tests that are undertaken to result in that diagnosis are part of the record, are part of the claims history. And so that at least gets you that roadmap into understanding what's going on with that patient. Now, if a clinician trying to treat a patient looked at that, they would probably say, I need to know more about the detailed results of that test than what I'm seeing in the payer record, but at least now I know where to go look. Thus the use of the payer-based personal health record as a search engine to get you to that next level of abstraction. Does that make sense?
Yes.
How do you address the lag of time between the claims for the stuff and what a personal health record might have? Might take about my
Right. The question was, how do you address the lag in time? And again, I'm trying to draw a level of abstraction here that makes some level of sense. However, you're going to see something else develop in the health plan world here that, I listened to someone talk about, the exciting feasibility that was shown in the transfer of data here between Indianapolis and Boston and so forth. It reminds me of the fact that, in 1997, our company created instantaneous adjudication at the point of service, where you could know exactly at the point of treatment what would be owed to the physician and what the patient liability was. It's just that the market wasn't ready to handle that. But what you're going to see that's going to speed up the data here is this notion of what we're calling, in a consumer-driven world, let me just really quickly, the macroeconomics are that more of the responsibility for payment has shifted onto the consumer. So instead of a $5 or $10 copay, the consumer has to come up with more money, higher coinsurance, a higher deductible. This is creating a higher risk for physicians at the point of treatment in an ambulatory environment, and of course higher risk for the hospitals at treatment. So what's required now is something that we at TriZetto define as patient liability at point of service, where based on the benefit plan, the provider contract, and the medical management rules, you can get at that point of care what the patient liability is. You can only do that with a full adjudication system. That's the bad news. The good news is that's what we do. But the point is that's going to compel for payment purposes and for risk protection against patient receivables, that will compel physicians and hospitals to enter data at the point of service. Ideally, we would coordinate that with practice management and hospital systems vendors.
It's currently a showstopper.
It's currently a showstopper, but you know what? The dollars involved that were at risk for the physicians in the past were so nominal, it could never get done. Now it is, you might be 6 or 8 months through the year before the insurance company incurs their first dollar of liability versus the patient, where it's all coming out of their pocket.
Yes, Adrian.
In terms of this excellent spectrum that we've gone through here, it seems to me you've pulled a bit of a fast one moving to the SNOs, because you said that the SNOs involve an MPI arrangement, which isn't the maximum amount of patient control. There is something, well, as Sweden proved, I think, indirectly, there is an element of coercion in having federation of the various other models.
Well, I'll just point out that's why the patient control only got one Lincoln Memorial in that model. So I think we're in agreement there. Once you put your data into these networks, the loss of control, I think, is substantial, and it may be a trade-off that is well worth it. But I'd like to take the opportunity in these 2 days to think about what that trade-off is.
That's another argument for the payer-based record, because at the point of enrollment, to have health benefits, you must actively enroll. At that time of enrollment, to the earlier gentleman's question, you can designate the permissions of usage of your data in an active way, and by the active enrollment, as opposed to passive enrollment, you can make sure that the transport and security behind your data is better controlled.
Yes.
I'd like to raise another aspect of knowledge about the patient and consumer profile that I haven't heard yet. I know that over the past 5 or 10 years, we've done increasing research about what kind of people are interested in this, what kind of people are interested in that. We've got some sets of those who are using any kind of default tool. But as we enter into this far higher level of personal responsibility, what I would have loved to have in this dialogue is someone who could be educated enough to look at these and start talking about the trade-off. There are a lot of people, bright people in this room, who no longer change their own oil. There are a lot of people in this room who no longer install their own audio system. A lot of trade-off. And while the transactional service, the transactional benefits of this appear to be great, and while we all know whether we like it or not, we have to do more of this for ourselves. Nevertheless, I think it would be very useful in the development of these models to have someone thinking of that consumer perspective as we move forward.
Yes.
Just to amplify that, the notion of entering your prescription expenses and such to get your healthcare account reimbursement might be one of those different. And that's just for everybody. And if you had that as an automated part of your life, that would be a different thing.
Yes. Mike.
In this room, I know we've had that we're going to restructure the
answer the question. It's the stuff that you've got is the person who's really sick, or they're really great, they're using spreadsheets and calendars to track their appointments. But what it doesn't do is interoperate with the healthcare.
It's a matter of
software has been a rallying cry of defeat for the last 40 years.
It's a matter
in
of
the healthcare
it's
industry.
a matter of aggregation, not just software.
Right. Patty.
No, you should have, well, you should have all of that information. You're working. Will the payer, you mean? Yes. The payer, the consumer still needs to understand what the payment portion of the health plan will or won't be. And so you still need to vet it through what's called an adjudication transaction. Right, because you might have a high deductible health plan that pays preventative, and if the health plan is going to pay preventative, this is kind of, if you remember the days of capitation, this was a big thing when I was a chief information officer. A lot of health plans took the position of, we're not going to capture the encounter data. That's the physician responsibility as the health plan because it's their problem. I always took the opposite view. The health plan will never give up a piece of data. Never, never, ever. That is the way we design our applications and the way most of our customers think. Okay, so that's the billion-dollar question. But I will tell you that it was mentioned in the first presentation by John that the health plans and AHIP, the American Health Insurance Plan Association, are working to ensure that there will be a agreement among health plans to create and allow transportability of personal health records even among competing health plans. And I believe that every payer I've talked to, with a few exceptions, are committed to that kind of reality.
Any other questions? One last question, and then we go to refreshments.
A question for the panel, if I may. I'm wondering, as a growing number of Americans lose their health insurance coverage and aren't yet covered by Medicare or Medicaid, under the payer plan, the custodian of those records, where then do those growing number of lives, how do they have access to PSP as well?
So are you talking specifically about the uninsured? All right. It's a social question that goes beyond technology question, right? Because if you break down that 52 million people, about a third of them, might really be underinsured or have some level. A third of them probably can't access anything, and a third of them are sort of in that mid-range. But what I'll tell you is that what I'm seeing is whether it's payers or governmental entities, state Medicare sorts of, or Medicaid sorts of issues, is people are understanding that you need to still get these people aggregated into some population control system that looks like and acts like the systems that payers use to enroll and aggregate population. And then off of that, I would like to see reimbursement requirements get tied to the population of or the initialization of a personal health record in those cases, and I think we could create a carrot, not a stick.
Any other comments? With that, I'd like to thank our panel.
Not quite yet. I just, after, we're about to have a break, and then after the break, we're going to have one more plenary panel. And after that plenary panel, we're going to split into 3 different groups. The oft-mentioned technical and standards track, business models track, and societal issues track. So There is a section in the program book which describes the goals of those tracks in a little bit more detail. We'll be having 3 separate panels, one in each track, setting the stage for some more focused and detailed discussions within those contexts. So if you haven't had a chance to take a look at that, you might want to do that during the break. And I would just want to point out that, and we described this in the introduction to the track concept, all of these tracks are really looking at the same core issue, which is how do we create a productive, effective, patient-focused personal health record infrastructure. And they're looking at it through 3 different lenses. But that does not mean that any particular issue and any particular slant on any particular issue can't be brought up in the context of any of those tracks. So, keep an open mind, take a look at what's in there, and we've got some great panelists for all of them. And then that's what you've been waiting for, and we'll give you the full half hour, so we will start back at 3:50. So, thanks.
No, thank you, you too. I love what you guys are
Oh, and
doing.
could the next panel just come up quickly?